So the next presentation is going to be in English. Alors, la prochaine présentation, ne partez pas. Je vois quelqu'un se lever, mais je rigole. Va être en anglais. Donc, nous avons choisi de procéder ainsi. Déjà, je vais vous présenter Kirsten Ostherr, qui est la Gladys Louise Fox Professor of English, donc professeur de la chaire Gladys Louise Fox en anglais, au Medical Futures Lab, donc au laboratoire des futurs médicaux, à Rice University, au Texas, à Houston. Et nous sommes absolument ravis de l'accueillir, puisque Kirsten a participé, a écrit un chapitre dans le livre coordonné par Céline Lefebvre et Alexis Zimmer sur les humanités médicales. Et aujourd'hui, elle va nous parler. Alors, nous avons distribué un abstract en anglais et en français. Elle va nous parler de la médiation technologique de la personne en médecine, des images visuelles à la mise en données de la santé invisible. Cette présentation, vous allez avoir un certain nombre de slides qui vont bien sûr l'illustrer, donc vous devriez facilement pouvoir vous repérer si votre anglais n'est pas complètement, est encore un petit peu rouillé. Et ce que nous avons choisi de faire plutôt qu'une traduction simultanée, c'est de faire 3 pauses au cours de la présentation qui seront des pauses pour des questions de clarification. Et à la fin de la présentation, nous aurons une pause générale pour des questions sur le contenu. Donc, si vous avez des questions de clarification, vous pourrez les demander au cours de la pause et j'essaierai de traduire ce que peut-être vous n'aurez pas compris ou vous pourrez reposer une question en anglais ou en français. Je la traduis volontiers à Kirsten Ostherr. Voilà, merci beaucoup.
Great. Thank you all very much for being here, and thank you for the invitation to speak here. I'm sorry that I cannot deliver my lecture in French, but hopefully the slides will help illustrate the points I'm trying to make, and I welcome any questions about clarification in the pauses, and of course about the content afterward. So my lecture today will discuss the historical importance of images and visualizations in medicine and the role of this area of research for medical humanities, as well as the shift towards from images towards data in clinical and metaclinical contexts in the contemporary era. So I will explain how medical humanities can engage these topics through critical frameworks on techno-mediated health. And there will be 2 parts. The first part is medical visualizations, and the second part is health datafication. And the larger point that I really want to make is that both of these, I think, are extremely important but understudied areas in medical humanities, both from the point of view of medical humanities scholarship, but also from the point of view of clinical context. So these are both features of clinical environments, visualizations, and data that are pervasive and have strong influences, but that we haven't fully analyzed as far as how they impact doctors and patients. So I'm sure this image is familiar to many of you. Since the discovery of X-rays in 1895, the practice of medicine has really required doctors to develop the ability to engage in sophisticated analysis of visual images in their practice. This practice has included extensive debate about establishing conventions for interpreting visual diagnostic images, as those debates occurred at the dawn of what became the field of radiology, and as happens with the introduction of every new important imaging technology like CT, like fMRI, and so on. In looking at these debates historically and in the contemporary moment, we can see that medical visualizations change not only what we see, but also how we see. Knowledge itself, therefore, changes with shifts in mediation. In the late 19th century, when X-rays were discovered and cinema was invented, scientists used visual media, including photography and moving photographs, to provide a visual record of experiments, to investigate and document diseases, and to register scientific data. The X-ray peered inside the living human body at a time when that space was otherwise unavailable to human eyes, without risking serious morbidity and mortality. The resulting scientific images were often understood as providing the capacity to see truths that were otherwise unavailable to the naked human eye. The well-known motion studies of Edward Muybridge and Etienne Jules-Marais similarly use photography to attempt to understand the relationship between externally visible and internally invisible pathologies of human development. And this is one image from a set of studies that Muybridge did with a clinician collaborator in 1885. Here is another series of images from those studies. So this was sort of pre-cinematic, where he was trying to establish serial photography in very rapid succession, what became cinematography. But in order to capture what happens during movement that is not available to the naked human eye. So these are the images he's most famous for. The series of images of galloping horse that were made to try to settle a bet with Leland Stanford, the founder of Stanford University, about whether or not, when galloping, a horse's forehooves are ever all off the ground at the same time. You can see in the top row of images that indeed they are. So here are some of Marais' images. So he used a different kind of approach, but you can see again the use of serial photography to capture the body in motion, to try to visualize things that were otherwise invisible to the naked eye. Now, there's a long trajectory, and I'm not going to go through every moment in the development of photography and cinema for uses in science and medicine, but I want to move forward a little bit to 1924, where Francis Galton used a different kind of serial photography, and in this case, this series is called The Jewish Type. As you know, under social regimes of biopolitical control, the desire to visualize the invisible interior was often driven by the belief that the body's interior held racial, ethnic, class, gender, sexual, even religious essences that could be seen and interpreted off the surface of the body, especially with the aid of photographic technologies of representation. And that was very much what Galton was pursuing with this series. He made many series. This is a series of criminal types. He had many like that were attempting to capture different forms of social definition that he and others who were active in the field of eugenics believed could be seen on the outside as representation of the internal essence. So photography was also used for institutional regulation and categorization, or archiving of people according to typologies. So creation of images of the other was enabled by the use of the camera in the name of scientific inquiry. Now, this is jumping very far ahead. This is an image from the TV series House MD. The continued pursuit of visualizing the invisible, seeing in the mind's eye what cannot be seen with the naked eye, has characterized many scientific fields now for centuries. But since the discovery of X-rays, this drive has strongly characterized medical science as well as the popular culture of medicine. And that's another reason why I think that these forms of representation are extremely important to integrate in medical humanities. So we see this especially, this impulse, in the form of the desire to see inside of the living human body, and in particular, the desire to go inside of a living human body and see from in there. You see that impulse in science fiction films, such as The Fantastic Voyage, a science fiction film from the 1960s, and in the Visible Human Project, which is represented here, which was an undertaking by the National Library of Medicine in the United States some years ago now, that produced a series of images that were meant to create the possibility to have a fly-through effect. So to look through the different parts of the human body and see them in relation to each other, but as if there were space inside that one could occupy and look around. So these are images from the Visible Human Project. So this body was scanned using MRI and CT and then sliced and photographed. Catherine Waldby has written extensively about this project, and she notes that the Visible Human Project, launched in 1994, forcibly brought to public attention an old nexus between medicine, violence, and punishment. The Visible Human Project, she says, is the first virtual three-dimensional anatomy atlas of an entire human body, produced, like all anatomical images, through the dissection and rendering of actual flesh-made bodies. The project received extensive public attention in part because the first body to be imaged, this one, was that of a man named Joseph Jernigan, who was a convicted murderer who was executed by lethal injection. Here's an image of Fantastic Voyage. This, I will just, it's a casual anecdote, but I will just say that I've heard dozens of scientists mention this movie, which is a very silly science fiction movie from 1966 starring Raquel Welch, if anyone remembers her. She gets attacked by antibodies in one memorable scene. But many scientists have named this film as inspiration for thinking about the idea of advanced imaging technologies that can be so small. Now the vision is to go inside the brain to look around and see what's happening when people are thinking. But this is kind of a continuous fantasy that we've been pursuing for a very long time. However, the analysis of clinical images within medicine, when conducted without the insights of humanities-based analytical frameworks from visual theory or socio-technical frameworks from science and technology studies, can leave clinicians and patients unprepared to understand the relationship between clinical and cultural imaging modalities, despite the demonstrated influence of each domain upon the other. And as an example of that, I show you here ultrasound that is integrated into an invitation for a baby shower. So it's a classic example that many scholars have written about. Ultrasound became a cornerstone of diagnostic medical imaging in the 1980s, but studies soon demonstrated that the use of the sonogram in obstetrics only minimally affected pregnancy outcomes in normal pregnancies. So that is, it was not a crucial diagnostic procedure to monitor normal pregnancies, but nonetheless, ultrasound very much took hold of the popular imagination, and it's been used extensively in political debates. Here's another image of one of those baby shower invitations, as well as a cake for a baby shower that you could get made with the sonogram put on top of it. So let me just pause there for a minute, and you can ask if there's any questions.
Vous avez besoin de clarification sur quelque chose? Sur le gâteau, oui.
Qu'est-ce que ça serait la traduction de baby shower?
Baby shower, c'est une fête qu'on fait avant la naissance, pour avoir tous les cadeaux avant la naissance. Qui est...
Ça porte malheur?
Non, bah, en France, oui. Donc, et il y a des listes de baby showers. On le trouve dans toutes les séries américaines, enfin, où il y a des bébés. Donc c'est vraiment, mais c'est, it's only 8 months, right?
8, 9, yeah.
Ouais, le 8e ou 9e mois, c'est vraiment.
Any others? No? Okay. So I want to now just give you a couple of examples of some current projects that I'm involved with that aim to not just bring a humanities perspective to analysis of images, but then integrate that into clinical settings in collaborations with physicians. So this is work that aims to bridge clinical visualizations using media theory and visual art-based practices. And in particular, I want to highlight the rationale for bringing media history and theory into direct integration with clinical practice. I've called this, in some cases, applied media studies or applied digital medical humanities. And what I have found consistently is that humanities scholarship that directly intervenes in clinical practice by framing research problems through collaboration with clinicians or patients. So that's very important. It's not that I come up with the project and bring it in, it's that we come up with it together. It brings strong and very obvious benefit to both sides. So I'll just talk briefly about a couple. This one, medical visualization technologies as tools for patient collaboration. This is a project I have with colleagues in Berlin at the Charité hospital there. And what we have been doing, we've been teaching a class together in the medical school there and doing research on the effects of this approach to teaching, which basically is focusing on the role of screen-based images in real clinical settings. So if you look at this image, I've counted how many screens there are in there, but there's at least 1, 2, 3, 4, 5, 6, 7, 8, I think 9. This is in a high-tech operating room, but it's not that uncommon, and I'm sure it's very similar here. So the idea is, when you are in a clinical setting, you are surrounded by images constantly, right? And you learn how to read them and interpret them in a particular way that's very functional, but they all have different aesthetics that show different meanings based on the different modes of representation. So we are trying to teach these medical students, here's an image of them with 3D glasses on looking at a 3D rendering of a tumor, which they've also seen in other 2D modalities, to teach them how to understand how these images are made and how that relates to the meaning you can make out of them as a way to then use that to better communicate, to use the images as communication tools with patients. And I'm happy to talk about this more later. I'm not going to go into a lot of detail right now, but here's another image. One of the things that we do is we have them understand this in part by actually sketching or attempting to sketch three-dimensional images to get a sense of how objects in the real world can be converted into different forms of representation and what is removed in the process of doing that. So they do sketch a three-dimensional skull that way, and here you can see a couple of students working on that. They all say that it's one of the hardest things that they've done in medical school, but also the most rewarding when they finally get to the other side. Here's just a montage of those images, but I like this quote. What we perceive can only be perceived because we are able to imagine it. And we can only imagine what we can imagine by linking experiences of perception with experiences of movement. So part of the point is that there's a tactile dimension to performing surgery, which there also is in doing these drawings, and it helps them link together the images and the practice that they do in the operating room. Okay, let me also just mention another set of experiments like this. These are based in Houston at Rice University, along with in the medical center there, where there are numerous hospitals and a couple of medical schools. So I run the Medical Futures Lab, and we run a class in there where teams of students work with clinicians to solve real problems that they have that are visualization or communication problems that they have. They could be between physicians or between physicians and patients or between patients and nutritionists or other members of the clinical team. We call this, as a class, Medical Media Arts Lab. So the students, the problems that they work on come out of extensive dialogue that I have with the clinicians beforehand. So I'm not the one creating or defining the problem, but as they start to define it, we work together to frame it in such a way that it is both graspable, but also not just kind of like, I know the answer, but you know, let's see if you can guess it in the space of a semester. It's truly a problem that they need help solving. And here's just one example of that. The problems were always stated in the form of a question. So this one is, how might we redesign hospital discharge planning for pediatric liver transplant recipients to reduce medically unnecessary inpatient days? That might not seem like a very humanities-based problem, but the way that it was described to me in our conversations with the liver transplant team was that part of the reason there was huge variability in length of stay was that there were communication problems between all of the many different teams that had to be involved in getting a patient from transplant to discharge, including especially teaching the parents, who these are often very young children, teaching the parents who will care for them after they leave to do so in a way that will be successful. So what this led to was very surprising to everyone involved, but especially to the clinical team. It came out of the fact that in this class, the students, they read media theory, but they also read theory about digital health technologies, and they learn about the healthcare system. And what they ended up doing was making a short film. I'm going to show you just a little clip of it now, and I'll describe it to you. Let's see if this will work. Here we go.
Hi, I'm Jenny Smith, and this is my daughter. What's your name?
Peyton.
This is Peyton Smith. She was diagnosed with biliary atresia at 8 weeks. She had a Kasai and then had liver transplant. Can you stand on this chair? Hold on. Come here. I want you to show them something. Can you show them your rainbow? Where's your rainbow? Right there. So Peyton's liver transplant was right here. Where's your liver? Where's your new one?
No.
Right here? Right here. So the main medication that your child's going to be on for life is tacrolimus or Prograf or Rapamune. It's the immunosuppressant. You're going to be taking it in 12-hour increments. So we take ours at 9 a.m. and 9 p.m. It's really important to take the medication right on time because the 12 hours of coverage ends, and if you're late, that gap, even if it's 15 minutes, it's 15 minutes that your body isn't covered and your body could start attacking the organ because it doesn't think it belongs.
Okay, I'm just going to show you that little bit. The point I want you to see from this is this ended up being, what the team realized was that the parents had a lot of downtime. They were waiting and waiting and waiting while their child was in the hospital. Meanwhile, there was all this information that was being conveyed to them in very complex medicalized terms. And the student teams, in the process of interviewing many patients and their caregivers and observing the processes that go on in the hospital, realized that the parents could teach the other parents. So it's a peer-to-peer kind of education, a patient empowerment thing, you could say. And so she's talking to other parents. And what the clinicians and the other parents loved about this was it showed the reality of a squirming child who doesn't want to sit still, and she explained why you need to take the pills when you need to take them from a caregiver's point of view, not from a clinical point of view, even though it's conveying that meaning as well. So that's just one example of a kind of a project and one of the outcomes of it. So they went on to make a bunch of these films on different topics with different parents. But the key that I want you to take from this is that this was a collaborative process between humanities people and clinicians, right? It wasn't, there was some real value in it for both sides, but it was bringing our expertise in thinking about media and technology to address this problem that they had. I'll just quickly show, this is a book that came out recently that is a series of academic essays. There's Rosemary Garland Thompson again, she wrote the foreword, based on MRI scans that it's done by two sisters, that one of these sisters has of her own body that the other sister made into artworks, and then analysis of those partly with therapeutic objectives. They're really interesting images. Okay, I'll pause there again if there are any questions.
Est-ce que vous avez des questions pour clarification dans ce qu'on vient de voir? Le film ou le procédé avec les étudiants?
Une traduction complète?
Non. Non, parce qu'on est déjà court pour le temps. Je peux le faire au café après, au cocktail.
Yeah, okay. All right, I'll keep going. So I've been going, I might go skip a little bit in this so we can get through all. So, okay, so I'm shifting now. That was the health visualization. I want to shift to health datafication now. Because I see an analogy in the present moment, like the gap between cultural analysis of images and clinical use of images, I think there's also currently a gap between biomedical understandings of patient data and cultural understandings of health data as medicine becomes increasingly data-driven. Members of the general public, including patients, are playing a more and more important role in collecting data about health and disease. And this is a practice that I think we need much better understanding of as it impacts patients and doctors, and we heard a paper touching on this yesterday. So I want to use this term datafication, which has been defined as the effect of individual actions, sensory data, and other real-world measurements, creating a digital image of our reality. It's also been defined as a process of rendering into data aspects of the world not previously quantified. And this is the real pressure that I think requires humanity's attention. So transforming data into actionable forms also creates diverse and unevenly distributed kinds of value for their producers and consumers. So this is a practice that commodifies the behaviors and exposures of daily life, generating new forms of value. These practices occur both within and beyond clinical settings, posing challenges to traditional understandings of agency and ownership of medical data. This situation came about as a result of a larger phenomenon called user-generated content, which I think everyone is familiar with, the content that populates platforms like Instagram or Facebook or any of the major social media sites that without users' content are nothing, user-generated content. So wearable technologies, you can't really see that slide, but it's a sleep tracker. Wearable technologies from Apple, Fitbit, Xiaomi, and Huawei in China and Garmin have created an abundance of user-generated health data. This is a multi-billion-dollar industry, and it's producing more and more data that's being used in medical settings. However, these data are produced, shared, and exploited under poorly defined privacy and ownership policies. So in terms of implications for public health, these vast data sets are widely seen as providing new sources of insight from exposures in the wild, creating the opportunity for new research discoveries. But as the field of medicine has begun to embrace big data, a very problematic equation has taken hold, which is more data equals more knowledge equals better health outcomes. I want to ask about the assumptions that are embedded in this equation. Particularly, what new kinds of knowledge might these insights reveal, and for whom might they improve outcomes? The novel achievements of user-generated health data rely heavily on participants' willingness to share their own data, even when doing so may not serve their own best interests. Therefore, questions about data ownership entail questions about trust, privacy, and sharing. This is a research area that I published a paper about with some of my grad students in the journal Big Data and Society. And I want to bring this topic to bear on the field of research on social determinants of health, which the World Health Organization has defined as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. I would propose that as a ubiquitous feature of daily life in many, many parts of the world today, datafication may be a new social determinant of health with the capacity to shape the conditions of daily life. And that includes for people who are, quote, are data rich, as it is sometimes called in the field of data analytics, and those who are data poor. It affects both of them and may indeed reproduce health disparities that this kind of data collection is supposed to help ameliorate. So, if wearable health technologies capture social determinants of health, can they democratize access to care? Will they exacerbate health disparities, or both? Here's another image full of medical screens. This is from a popular culture. It's from the series The Handmaid's Tale, if anyone has watched that. Inside of medical spaces, the practice of medicine is both heavily mediated by screens and heavily mediated by devices of quantification, and that's increasingly true outside of clinical spaces. Almost any behavior or exposure that can be sensed and digitally quantified becomes reframed as a health behavior available for datafication, intervention, and optimization. This raises questions about what becomes of the human dimensions of suffering and healing in techno-mediated medical systems that pursue scalable clinical improvement through artificial intelligence, machine learning, and other computational approaches that seek to convert the nuances of human communication and bodily expression into crunchable data sets. So what is the role of medical humanities in addressing these concerns? I think that these conditions create a field that is ripe for humanities and digital humanities intervention that I have sometimes called digital medical humanities. Like the field of critical code studies or software studies, this emerging field integrates historical and theoretical frameworks with applied interventions that aim not only to critique but also to transform their objects of inquiry. Much work in the medical humanities is premised on the idea that patients' voices, we heard this in the previous panel, patients' voices must be better represented to help address structural inequalities that are removed from narrowly biomedical approaches to care. In the era of big data, this is both a human problem and a computational problem. One doctor can listen to one patient at a time, but artificial intelligence can listen to thousands or millions of patients at a time. So say advocates of this approach. Though I am skeptical that artificial intelligence algorithms are capable of accurately interpreting the subtleties of human communication, I am convinced that significant patterns and revelations could be found if we were capable of distant reading the patient narratives buried in healthcare's big data. It is undoubtedly true that big data analytics need to develop better human contextual sensitivity to produce meaningful results. It is also true that the capacity to interpret personal health data in relation to population scale data can yield discoveries that benefit patients precisely because they situate the individual in relation to the mass. Back in 2007, I have a citation up here that was published then called E-Patients, How They Can Help Us Heal Healthcare. Back in that moment, people like these researchers felt that the internet offered valuable new kinds of connection and collaboration, and they would argue for the importance of listening to and amplifying patient voices in healthcare settings. The argument in those days was for openness, inclusivity, and experimentation with new technologies, as well as new forms of communication and information sharing, and for validation of patients' voices gaining expression online. This was often perceived as an uphill battle against the paternalism of traditional medicine. But at the same time, traditional medicine, such as the American Medical Association, for example, was advising doctors don't participate in online dialogue. It's risky and it will be bad for your professional reputation. Now, just so you don't think this is a kind of outdated and passé model that no one is pursuing anymore, are any of you familiar with this ad campaign? So this was an ad campaign for the Belgian government that just came out 2 years ago, whose theme was "Don't Google it, check a reliable source." I can tell you more about that later if you want. But so the old challenge was perceived as convincing traditionalists that patients connecting online can be good for their health outcomes. However, the new challenge, now that many people are participating in online dialogue, is managing the unintended consequences of connecting online, both for health and beyond. In the interest of time, I think I will, I'm going to jump ahead just a little bit in my presentation. What I would like to talk to you about just briefly is the Facebook Cambridge Analytica scandal as an example of why medical humanities needs to engage with questions about big data and trust and privacy and the ethical implications. I will tell you, I did a lot of research on Facebook and health data when this was happening, so I'm going to use that as the example, but they are not the only company who's doing any of these things. All of the big technology companies around the world, especially in the US and China, are trying to get into health data and clinical practice. And so these concerns are relevant globally, and that's why I think humanities scholars need to get involved. So let me just say, so this was a piece that I published in the Washington Post newspaper about this. They made up the headline, not me, but that kind of captures it. Facebook knows a ton about your health and now they want to make money off of it. Briefly, Facebook was sued in 2016 by a cancer patient who discovered that Facebook was tracking his activity in patient groups hosted by hospitals. That he thought were private, that he was told were private. So therefore the company knows that patients don't like this, okay? But they keep doing it. They held a health summit in 2017 that was designed to attract more business from pharmaceutical advertisers. And to attract their business, they offered a unique feature that they don't offer to other businesses, which is the capacity to turn off comments so that they could better control the public representation of the advertisements of their drugs. They also started a project that was reported by a reporter at CNBC, where they sent a doctor to hospitals in the San Francisco area to try to get them to partner to share patient data without asking their consent, so that they could see whether they could match anonymized patient data with Facebook patient data. They put that on hold because this story broke right around the same time as Cambridge Analytica, so they were getting enough bad press at the moment. But the thing is, true anonymization of data is virtually impossible. We can talk about that more, but I'll just skip ahead to kind of get to the point here. This is an example of a patient group on Facebook and the kinds of sensitive information that are included and available for third-party data brokers to scrape. Just that list there is just some of the many kinds of personal health information that's available there, okay? But this is exactly the outcome of the movement that patients started in the early days of the internet to share information, to support each other and take charge of their own health by sharing information with others like them who knew better than any clinician could what it was like to live with disease. So this is a real problem for patient groups. And in fact, one person I know who is a moderator of a breast cancer group on Facebook, when I spoke about this research, she started looking at what kinds of data were being scraped from her website, from her group, and found that in fact a Google Chrome web browser was scraping information from Facebook. So it's, you know, it's not just Facebook. The point I want to make from there is that her group protested to Facebook. Initially they did nothing, they protested again, and eventually they got Facebook to remove this capacity. So, and I think that's very important because their action was the result of our discussion based on humanities research that's about questions like trust and sharing and openness in technological platforms, but it led them to be able to make moves that eventually made a small change in this site. Okay, so I think that there's so much more I could say about this, but in the interest of time and dialogue, I will stop there. So thank you very much.
Alors, si vous avez encore des questions de clarification, je peux ajouter, mais bien sûr, vous pouvez vous poser vos questions en anglais ou en français, comme vous le souhaitez. So I will start. You mentioned earlier, I think I wrote it down, that I was very interested in the problem-solving work that and I was very interested in the fact that these are real problems.
Yeah,
I thought this was wonderful, both pedagogically, but also on the ways in which professionals would look at students and interact with them. And I was wondering, because you mentioned that the problems were from clinicians, do you also have either patients or other actors of health come and share their problems, or is it mostly clinicians?
So far, it's been mostly clinicians, including sometimes a biotechnology engineer who was embedded in a hospital, or a nutritionist as well. We've had extensive debates about this, because ideally the problems would come from the patients. But what we see is a challenge, which is that although we are trying to intervene in hierarchies, knowledge hierarchies and power hierarchies in medicine, they are real, and in that environment, it is doctors who can make things happen. I mean, doctors can literally write orders, right? And nurses cannot, except with the doctor's approval, and patients cannot. So the way that we have worked, so we want these solutions to actually be capable of being implemented. So the way that we address the patient perspective in there is that we have always, the students go and do research on site where they interview patients or caregivers or both, depending on the nature of the problem. And we have those patients come. We have several critiques in the course of the semester where the students present their work so far. And we have patients and other people who are placed from that perspective come, not always patients or caregivers with that condition, but who are bringing that perspective, and sometimes those who are part of the clinical setting, research setting, and they give their input at the various stages, and then as the students develop prototypes, they show it to the patients. They sort of pilot test it and get their feedback that way. So that's the way that we've addressed that issue so far.
Mm-hmm.
Yeah.
Vous pouvez vraiment parler français, hein? Il n'y a pas de problème, je traduirai.
I didn't properly get if the students' training you were proposing, it was from the tactile experiences. It was for doctors, future doctors, or any other kind of students?
The students are mostly pre-medical students,
Okay.
but not entirely. Sometimes they're just students interested in this class. They like it because it's a problem-solving class that has real-world kind of payoff in a way. They find that very satisfying. So sometimes they take it, students who are not planning to go into medicine. And by design, whenever I can, I get a very multidisciplinary class so that the teams can be multidisciplinary. So I often have a lot of engineering majors, but one whole team of engineering majors isn't a good team for this kind of project. Ideally, there's an engineer, there's maybe a visual artist, there might then another kind of humanities major, like an English major perhaps, and maybe a psychology major or a sociology major. And when you have that kind of combination, it's usually teams of 4, they balance each other and they start to see what the other perspectives can bring, which is really important to this process, because the impulse often, especially from my engineering students, and I love my engineering students, is not a critique of them. However, they want to solve the problem immediately. Yes. Immediately. And the whole process is structured to force them to slow down and really understand the problem from the ultimate user's perspective, which is usually a patient. Sometimes it's a clinician or a nurse, or some other specialist in the hospital, but usually it's the patient. So I have lots of different processes that they use to slow them down, to understand that perspective in depth and detail. And part of the goal of that is for them to then, in a sense, redefine the problem. So that's one of the first steps, is once they start to really understand it from the end user's perspective, how does that change what they see as the real core of the problem?
It's very interesting, because I think it's the point which is not so developed here in France, this point that knowledge can and should go through corporal and tactile experiences, and it's completely lost, that kind of knowledge. So I was very interested.
It's very difficult for the students, and that in itself is very I think illuminating. Just that it's such a struggle.
Do you have some personal outcomes, returns of their proper experiences?
For the medical students, is that? Oh, do you mean the ones in Berlin that are doing the drawing? Yeah. Well, what we've been doing is over the 3 or 4 times that we've taught this course, we've had the students have been doing some reflective and analytical writing, which we are analyzing in a study now to see how they report on their own perception of both how they make sense of technology in clinical settings, but also how they see it as a tool for communicating with patients. I don't know, I mean, it would be lovely to see how these students perform as clinicians, but that's...
It's difficult to evaluate.
Yeah.
Okay, thanks a lot.
Yeah.
One final question, because we need to move on afterwards, unless someone else wants to. Okay. Oh, you have one. Okay, you go.
So you spoke about how medical visualization can be used with patients as a communication tool, but I was wondering if we can use it with mentally ill patients, considering the various approaches. And how these methods are still a bit understood, how there is a lack of understanding on an ethical point of view, I guess.
Yeah. Yeah, that's a good question. I mean, I will say that of the different kinds of experiments I'm aware of in hospitals where, say, patient records are being opened to them for dialogue with clinicians and that sort of thing, usually the one exception area is mental health. But I think that, I mean, in the case, in my collaboration in Berlin, for example, it's neurosurgery is the field that we are working in, and sometimes actually these tumors do affect people's personalities. So it's not maybe mental illness in that sense, but the challenge of understanding the patient's perspective and then adapting the communication to meet that is there in that setting as well. And sometimes it is because they're just not familiar with understanding an image like that. So there are many levels of the question of what some call health literacy, right? And it's affected by many things, and mental health could be one of them. So I wouldn't say that it's impossible in that context, but contextual awareness of the factors that are already constraining communication in all of these cases would be important before you decide how that communication would work. Yeah.
All right. Thank you very much
Okay,
again.
thank you.
Thank you.